introduce Dr. Carrie Jones. She's a neuropathic physician with a master's in public health who has over 12 years in the fields of functional and integrative medicine. As an adjunct faculty for the National University of Natural Medicine, she has taught courses in both gynecology and advanced endocrinology, right? What we're talking about. She has been the medical director of 2 large integrative clinics in Portland, Oregon, and she is currently the medical director for precision analytical. So Carrie, welcome. Dr. Carrie, I sure appreciate it. I can't wait to be curious with you too.
I just want to double check that you can hear me first before I move forward.
Yep, loud and clear.
Absolutely wonderful. So thank you so much. Thank you for the opportunity to speak to everyone today. I'm very excited. Cortisol is absolutely one of my favorite topics to discuss, and a lot of what I learned about cortisol, testing cortisol, the cortisol awakening response, I actually learned from Tom. So I really appreciate that he went before me so I can hear everything he said, and then we can continue on the conversation. So what's the deal with cortisol? Assessing our patients. We're going to be talking about the different ways that we can test cortisol for those patients that walk into your office. So first, we're going to identify comorbidities associated with the dysfunctional HPA axis, because these are the people that are coming to you and they're telling you all the symptoms that they're feeling. That they're getting their prescriptions, their medications, their HRT, and many a times you're probably thinking to yourself, "Wow, I bet you could use some additional testing. Like, I don't think this is the end all be all. I think we can do more for you." We're going to understand the markers needed for appropriate cortisol testing, and then learn the difference between serum, urine, and salivary testing, because there's a time and a place 100% for everything. So first and foremost, does this feel familiar lately? I want to say that I live in Oregon. I live in the Pacific Northwest, and we have been dealing with a multitude of wildfires. Hundreds of thousands of acres have burned. Thousands and thousands of people have been displaced, and it's been a very, very stressful last 2 weeks in the Pacific Northwest. And I happened to be in my pharmacy on Monday or Tuesday of this week, and I thought, kudos to the pharmacists who looked like they were on their very last nerve, their very last ounce of patience, and yet they were still, smiling and attempting to help people who were struggling with all the smoke that we were surrounded with, and their anxiety or their insomnia or whatever it was. And so I think this feels familiar to a lot of people all across the world, but the United States right now. So what's going on with her cortisol? I was talking to a practitioner, I was doing a consult, and I looked at the cortisol results and I thought, wow, her cortisol is a hot mess. What is happening here? And the practitioner said, Dr. Jones, she's stressed out. Everyone's stressed out. There's nothing you can do. But I need to know why her progesterone is low and why is she gaining weight. And I thought, if you don't address the cortisol, you'll never get that progesterone under control, and especially with that weight gain. And maybe not never, but the cortisol is really critical. Like Tom said, it's a glucocorticoid, and it has everything to do with our glucose management and insulin, how we handle insulin. And then on top of that, it deals a lot with our inflammation and infection and energy and alertness, and our sleep, our circadian rhythm. And so cortisol has everything to do with all of this. And there is a lot you can do, not nothing. So right now the world is struggling with illness, separation, social isolation, financial insecurity, bereavement, and death that will lead to a fallout with chronic conditions in both adults and children. And that's where we're going to get into these comorbidities so you can recognize how cortisol plays a very distinct role. So an elevated cortisol response, they have an increased or an upregulated fight or flight response. Their cortisol is high, their epinephrine, norepinephrine, or adrenaline might be pumping. So in mood disorders, these are your people that actually report melancholic depression. This is the depression where they wake up and feel most depressed in the morning. Cortisol can actually affect the way that a man or woman makes serotonin. So the higher the cortisol, especially in the morning, then oftentimes the less serotonin they produce. The cortisol will cause tryptophan to turn tail away from serotonin and go down something called the kynurenine pathway. So it's a pivot, kind of basically for survival, but it affects mood in the process. So high cortisol, anxiety, panic attacks, hypervigilance, right? That amygdala gets involved in the brain, that amygdala that is our fear-based emotion gland. And so it pushes us into hypervigilance, aggression, feeling stressed out, feeling overwhelmed. Insomnia is huge. It's huge right now in 2020. High blood pressure, coronary artery disease, diabetes, insulin resistance, metabolic syndrome. Cortisol plays a role in all of this. In addition, cortisol affects memory. We know that it can cause hippocampal cell death, and that can lead to memory issues. Not only even with aging, we tend to think of these memory issues as men and women get older, but many a times, I'm sure you've yourself, maybe friends or colleagues or coworkers, have said to you that they're going through a tremendous amount of stress and they feel like they're developing dementia. They will say to you, I'm so stressed out, well, maybe it's just 2020, maybe they're going through a divorce, maybe they're caring for somebody who's very ill, and they'll say, I can't remember anything lately. I have to keep a lot of lists. I'm constantly relying on my calendar. I repeat myself. Is this dementia? And it's the effect of cortisol that has on those hippocampal cells. Brain on fire. A lot of people will often report they feel brain on fire, and that can lead to symptoms of anxiety, panic, hypervigilance, things like that. Reproductive dysfunction, ovulatory issues. Cortisol downregulates GnRH, which is the hormone from the hypothalamus that then tells the pituitary to make LH and FSH. So women are experiencing weird cycles with the stress. They may have worse PMS, they may have irregular cycles, they may skip a cycle, they may not ovulate, they may struggle to become pregnant, and cortisol can play a role. And then GI dysfunction, dysbiosis, intestinal permeability, IBS. We know that cortisol and adrenaline can affect the mucus layer that is, essentially protecting the lining of the intestines. It can wear that down, and now it can make anything that you eat, drink, breathe, or swallow comes closer and closer and closer to that intestinal wall, which the body is trying to protect against, but cortisol can wear that down. Now, on the flip side, if somebody has very low cortisol, low adrenaline, epinephrine, low norepinephrine, they sort of have a low or decreased HPA axis response. What are the comorbidities there? Well, atypical depression. So maybe they don't wake up depressed, but they're sort of depressed off and on throughout the day or through the whole day or maybe later in the day. PTSD. We know those with PTSD, generally depending on how close it is to the incident, as they get further away from the incident, we find that their cortisol, specifically their cortisol awakening response, goes down. And then seasonal affective disorder. So for those of you who are living in a part of the world or country that is heading into fall and winter and it's getting darker mornings, that seasonal affective disorder can become amplified with low cortisol. You just don't have the oomph, right? You don't have the sun, you don't have the vitamin D, you don't have the warmth, you don't have the birds singing to get your day going, and you don't have cortisol as much as you should, and that's the problem. Burnout, less resiliency, insomnia, but because of over time, high cortisol can affect GABA and glutamate, and then as your cortisol drops down, if you don't regain that, if you don't and improve that GABA response, then you are still stuck with insomnia. And so, as Tom mentioned in his lecture, the brain, of course, makes a number of neurosteroids that play into this. Immune dysfunction, so they're more prone to infection, inflammation, and autoimmune. We need cortisol to incite and increase and improve our immune system, to put out the fire, to decrease inflammation. Hypoglycemia, it's a glucocorticosteroid, and so if you don't have cortisol to increase your gluconeogenesis, your glycogenolysis, to break down glucose, then you may struggle. Maybe even you start out innocently enough becoming hangry, where you are angry when you're hungry, or moody when you're hungry. And then over time, it could potentially get worse. Or just dysglycemia, right? You don't have an appropriate glycemic response. Again, memory and recall. The cortisol awakening response, which I'll talk about, and Tom mentioned, has a lot to do with in putting down memory and recall, especially for the next things you learn the next day. So tomorrow, Sunday, if you're trying to recall what you learned at the pharmacy symposium and you're thinking to yourself, what was it she said? What was it he said? Your cortisol is probably not very good. And brain fog. Reproductive dysfunction, again, possibly from perceived burnout. We know that the hypothalamic pituitary ovarian axis and even the testicular axis, gets a lot of input. It really takes cortisol, and it takes that fight or flight feeling into consideration when it's trying to determine if it should, create hormone, if it should release an egg, if it should prepare for implantation. And if somebody is in a high amount of fight or flight, then it's possible it's going to affect the reproductive outcomes. And then cancer outcomes, earlier mortality in breast and prostate cancer. We know a lower flatline cortisol has an earlier mortality, especially I see more research when it comes to breast cancer. So with breast cancer patients, when we do cortisol testing, if I see that sort of low flat line, they're missing their circadian rhythm, they're missing their up in the morning, down at night, then I'm working with their practitioner to really try to get that back, because we do not want earlier mortality. So improving a dysfunctional stress response can reduce these comorbidities, right? It all circles back to that HPA axis dysfunction and reducing the comorbidity risk. So this is one of my favorite quotes. I happened to read it earlier in the pandemic by this author. "In the darkness, any amount of light we can shine will be brighter than it ever would be otherwise." And I think that's really fitting right now, because you as the first responder, you as the first person a lot of people see, the first person a lot of people talk to when it comes to their health and they need help, where can you start? Obviously, addressing causes is where you're going to start in the basics, but when you're trying to narrow down or get specific, be individual with these clients and patients and people that you talk to, testing is absolutely a great way to shine the light, because, as I'll show you later on, sometimes when people say, "I can't sleep," it could be a few different things, or "I am tired," it could be a few different things. And when you test, you can hone right in on that. So Tom covered this, but I just want to review again, because we're all about memory and recall here. So cortisol basics, it's produced in the mitochondria, and I know a lot of you might be thinking, the mitochondria, isn't that the powerhouse, the organ, our cellular powerhouse we learned about in high school? Yes, absolutely, but your cortisol starts and then ends in the mitochondria. So mitochondrial health is actually really important to producing cortisol. It's the first and last stop of cortisol production. And then it's at the direction of ACTH via CRH in the brain. So brain health here is very important. So when you get to the treatment section later on today, paying extra attention to things that support the brain, nutrients to support the brain, nutrients to support the mitochondria. We know cortisol follows a circadian rhythm. It starts with the cortisol awakening response, which I'll talk about in just a second. So we're high in the morning and we're low at night. And when I mean high, I mean physiologically high. I don't mean super physiologic. Obviously people can have extremely high cortisol in the morning and they wake with anxiety and they wake with panic and stress, and that's different than a normal cortisol rise. Roughly 1 to 5% of your cortisol is free and active. It's that free cortisol that can bind to the receptors and do the things. If it's not free, then it's bound up on the binding globulin called cortisol binding globulin. It's also known as transcortin, and some of it's also bound up to your albumin. Your cortisol, your body is smart. Your cortisol can activate and deactivate itself into cortisone or back to cortisol through this nifty little enzyme called 11-beta-HSD. So 11-beta-HSD2 deactivates you to cortisone. Cortisone is inactive. It doesn't do the things. Cortisol is the active part. So your body knows it can kind of like, all right, this is too much today, or to a different particular gland, or because of the mineral corticoid receptors, it can deactivate to cortisone, and then another tissue, it can turn it back on again. So when you want to break down cortisol, this is where the testing comes in really handy. So as I mentioned, 11-beta-HSD1 activates, turns you on to cortisol, and 11-beta-HSD2 turns you off to cortisone. So you may have somebody who says, you know what, I'm really, really, really tired. And you test them and they make plenty of cortisol. The production is not the problem. But then you find out that their 11-beta-HSD2 is high and they're deactivating everything to cortisone. So production's not the problem, they have a deactivation issue. The flip side might be true as well. Somebody says, I'm very stressed out, I have anxious, I can't sleep. And again, their production is normal, so they don't have an upregulated brain to adrenal response, but their 11 beta HSD1 is elevated. They have an overactivation issue. And so it's really helpful to know these things, because then you're like, well, I don't need to address the brain so much as I need to help this little enzyme and, help the body not feel so fight or flight. So the majority of cortisol, when you break it down, that happens in the liver. So liver health is important here. And then you actually urinate it out, and it becomes these nifty little cortisol metabolites known as THF and THE. So THEs are your cortisone metabolites, THF are your cortisol metabolites. So why is metabolized cortisol important? Well, it actually represents about 80% of total cortisol production. So you need to know you're free. You need to know what's active and combined to receptors and do the things. And it's really helpful to know cortisone, so you can decide, like maybe this person is just a big deactivator. But I also want to know, like, how much do you produce? Do you even have the ability to produce cortisol in the first place? Like, is this a production issue? And that's where testing metabolized cortisol can help give you that answer. Because you may have completely normal levels of free cortisol at that moment, but if the metabolized cortisol is starting to drop, that free cortisol is probably going to drop soon thereafter. So what can labs tell us about cortisol? They can tell us the up and down pattern, which is called a diurnal pattern. We can talk a lot about the stress response resiliency, which is the cortisol awakening response, your total production of cortisol, and your metabolic preference. Do you like cortisol or do you like cortisone? Do you like active or do you like inactive? And what's great is that if you're seeing some of this stuff for the first time, just be aware that all of this is addressable. I don't even know if that's a word, but this is all very addressable. So once you can dial in on these things, like, oh, it's a production problem, let's support the brain and the mitochondria and nutrients and what have you, or oh, it's a deactivation problem, or it's an overactivation problem. Okay, let's address that. And so that's a really nice way to use these 4 checkboxes to hone in on that person. So with traditional endocrinology, what do we get, right? We get, well, if it's not Cushing's and it's not Addison's, then you're normal. You're normal. Like I get that you're tired and you have insomnia and you're gaining weight and your hair's falling out and you're not ovulating. I get that, but it's not Cushing's and it's not Addison's, so you must be normal. But really, what I'd like to say is that when it comes to this, we get into more of like a functional look, and that's where traditional testing is serum. So traditional diagnosis is Addison's and Cushing's. Traditional testing is serum. It's a single blood draw. Very, they can just do it at their doctor's office. Although not a lot of people want to get a blood draw right now. Not many people are really excited to go into a hospital or a lab to get their blood drawn. When you do a serum cortisol, the results are a combination of bound and unbound. Unbound means free cortisol, which is not that helpful. So if you got your blood drawn for cortisol this morning and your result was 10, you don't know if that's 9 bound up and 1 free, or 9 free and 1 bound up. So that's the tricky part, because you want to know, like, well, how much is active and how much am I making? So there's no value for free cortisol. There's no cortisone or metabolites or any kind of rhythm, because nobody wants to get their blood drawn 4, 5, 6 times during the day. So we propose a functional endocrinology model, which is, okay, got it. We'll make sure it's not Addison's. We'll make sure it's not Cushing's. We'll do our due diligence. But in between there, when somebody comes in and they don't feel great, like maybe they're just at one end of the spectrum or the other. They're more in the orange or the red on the low side, or the orange or the red on the high side. So it's more of this like functional sliding scale when it comes to their cortisol, and that's where we get into functional testing to better depict this. So along came salivary and urinary testing for cortisol. Now, this allowed for multiple collections in the day and at-home data. A lot of people right now in 2020, like I said, they don't want to go into a hospital. They don't want to go into a lab. And so having the ability to have easy at-home testing is really appealing to a lot of people right now, making it pretty convenient. So salivary cortisol became really popular because you could do it throughout the day and get that free cortisol. You could see your full circadian rhythm. You could test your cortisol awakening response. When you do it, there's 2 different ways to do saliva testing. You can free flow spit into a tube, or you can use salivate swabs, which are basically kind of like rolled up cotton swabs that you pop into your mouth and sort of suck on or chew on and then spit back into the tube. So ideally, The salivate swabs are better, especially for the cortisol awakening response, because it's a quicker collection as opposed to having to passively drool into a tube and wait to produce saliva. But you do have either option. The downside, though, you don't get cortisone, excuse me, you don't get the metabolites, and unfortunately, despite the fact that your salivary gland has a lot of 11-beta-HSD in it, a lot of companies don't include that marker as part of their testing. So saliva is great for free cortisol, you know, great for the cortisol awakening response, great for at-home testing, but missing a few things. Then came urinary cortisol testing. Now you can do 24-hour urinary cortisol testing, which misses the circadian rhythm, but gives you everything, the cortisol, the metabolites, what have you. And then you have dried urinary cortisol, which is where you urinate, kind of like saliva, where you collect through the day. You urinate on pieces of filter paper throughout the day. So you do get the multi-point circadian rhythm as free cortisol and cortisone. So you have both options, but the dried does give you the circadian rhythm. Both the 24-hour and the dried will give you cortisol and cortisone metabolites, and they will give you the 11-beta-HSD preference. Unfortunately, though, because of the quickness of how you have to test a cortisol awakening response, urinary testing, whether it's 24-hour or dried, is not good for the cortisol awakening response. And I'll show you why in just a second. We want to use saliva for that. So having said that, what a lot of practitioners are starting to do is do some sort of combination. So they're doing urinary testing in combination with saliva so that they get the cortisol awakening response, they get that circadian rhythm through the day, they get the cortisol metabolites, and they get that 11-beta-HSD, and now your 4 check boxes have been checked, and you can properly address the patient based on their individual results, which is really nice. So a typical 4-point response, if you're new to how cortisol works, kind of looks like this. So in this example, the gray shaded area is where you want to be, and the red line with the red dots is a typical normal person. So on waking, the cortisol is low, and then it will gradually increase. And some companies test 2 hours later, some companies test around lunch. Just depends which company. And then they'll test in the afternoon or around dinner, and then they'll do it again at night. And again, you can see it rises up like a mountain and then comes back down. This is your normal circadian rhythm, ideally, that you're following. So the 4-point collection is a great starting point. You get your rhythm, you can include metabolites, you can include your 11-beta-HSD, and you can include your cortisone. And this is a pretty standard way of testing for a lot of people and trying to get that rhythm. You're trying to hit that rhythm with your patients, with your clients. But then to take it one extra step, when you want to get a little more microscopic into how your patients are functioning, especially in the morning, we add in the cortisol awakening response. And how is the cortisol awakening response different? Why do you care about it? Well, we've shortened it to the CAR because cortisol awakening response is a mouthful, and it's used as one marker to determine resilience and flexibility. And let me tell you, in 2020, resilience is probably the word. If it's not new normal, it's resiliency that you hear over and over and over again, and it's with good reason. And the CAR is one of the things in the human body that helps us be more resilient. And by testing the CAR, we can test some of our resilience. It's one of the ways we can test our resilience. So it has been repeatedly been suggested that the CAR could be a result of the anticipated demands of the upcoming day, stress anticipation, and could support coping with daily life stress. So by knowing your CAR, by knowing my CAR, by knowing the CAR of my client or patient, I can get a really good insight into how they're really doing. Because, you know, sometimes you ask somebody how they're doing and they're like, I'm fine, it's fine, I'm fine, it's all fine. And then you look at your labs and you're like, wow, you're not fine. You need to work on this because we don't want you to start to develop comorbidities. So the reason that I test the CAR, the reason that I love the CAR is because it influences so much. The little action of the cortisol awakening response in the morning is amazing. It affects our alertness. Now, a common cheater method that I will do is I will ask you, how long does it take you to become alert in the morning? And if you tell me it takes you 2 hours and 2 cups of coffee, I know that your cortisol awakening response is not that healthy. because a normal car kicks in about 20 to 30 minutes after you open your eyes. In 20 to 30 minutes, you should switch from conscious to alert. And if you're thinking to yourself right now, yeah, nope, then you are probably struggling with some car issues. Now, other people might say, oh, I wake up and I'm immediately to a 10. I am on fire. I am either anxious or hypervigilant or on the go or type A or, whatever it is, I'm maxed out as soon as I wake up in the morning. That is also, it's not a healthy car response either. We don't want to go either way. This is like Goldilocks. We want it to be just right. Our car influences our energy levels, our stress response, our levels of feeling stressed out. It deals with our blood sugar management. A healthy rise in the morning of cortisol is partly because we have been fasting all night long. So the body will increase cortisol so that you can get some glucose in your system, because for a lot of people, you don't eat breakfast in the first 20 or 30 minutes. And for a lot of people, you don't eat food for hours. And it's cortisol's job to manage that. Your car, the health of your car can actually impact autoimmune development and progression. You have in your thymus gland, not thyroid, but thymus gland, you have thymocytes, so thymus gland cells, and the thymocytes help your immune system to, it's kind of like a checks and balances for autoimmune. So if your T cells and your immune system get created, and when they differentiate, when they mature, when they graduate from T cell school, your body first has to check them to make sure they're not autoimmune. Your body is smart like that. So it runs them through the thymus gland and says, let's double check to make sure that you're not an autoimmune T cell that we created by accident. And if you fail the test, you have to get destroyed. Unfortunately. Well, fortunately, right? We don't want autoimmune. Sad for that cell, though. So in my head, it gets pulled aside, and then it has to get destroyed. And one of the triggers, one of the instigators to get apoptosis to happen is that cortisol awakening response. It's one of the like, as soon as your car goes up, it triggers apoptosis to these failed T cells. If you don't have a healthy rise of cortisol in the morning, if you're more of a flat person, maybe you go down, you could potentially allow these failed cells to slip out and sneak out into circulation. And we don't want that. Cortisol awakening response impacts inflammation and infection in the morning, especially. So if you wake up in pain, you wake up and all your joints hurt, but then, 20 to 30 minutes, 40 minutes, you're feeling a lot better. It's because your cortisol's kicked in. Your cortisol's helping reduce your inflammation. But if you don't, it's possible you have a lower flat car. Memory and recall, this is where that healthy cortisol awakening response is, where tomorrow, if you're trying to reflect back on what I said or what Tom said or what anyone said today, you may not have the healthiest of cars. And then cancer outcome again. So how does it work? I keep talking about it. How does it work? So as awakening gets closer, your pituitary gland is trying to release ACTH. So basically, it's like a little kid on Christmas. It's your brain is trying to talk to your adrenals, and they're going, now? Can you make cortisol now? Now? Can we make cortisol now? Now? And the adrenals are like, no, not yet, not yet. He or she hasn't opened their eyes yet. They're still asleep, like not yet. So there's this blunting. But as soon as you open your eyes and as soon as light comes into your eyes, then it's go time. Then the adrenals go now, and the blunting releases. The ACTH is able to bind onto the adrenal gland strongly, and you produce a sharp rise in cortisol. At least a 50% increase in about 30 minutes, causing you to move from conscious to alert. Then you have a sort of like a rebound, so then you gradually decline, right? So you go up to a point and then gradually decline through the rest of the day. So you're nice and low at night so that you can fall asleep and stay asleep. But you'll see I have underlined and bolded is where it says light enters the SCN, suprachiasmatic nucleus, in your brain. Light is the key trigger here. Light, not ashwagandha, not magnesium, not thyroid medication. It's light that triggers this whole cascade. So let's keep that in mind. So when you collect the cortisol awakening response, it's quick. So in whatever company you use, you're going to collect your saliva immediately on waking. Then 30 minutes later, because of course it's supposed to rise in about 30 minutes and hit its peak. Then 60 minutes after that, after waking, and then around dinner, and then before bed. And then for a lot of companies, a lot of people struggle with insomnia, so they give you a tube or a saliva swab to do in the middle of the night if you happen to wake up. So you can see it's waking 30-30, and then around dinner and before bed. So that's why it's really difficult to get a blood draw there, and that's why it's sort of difficult to urinate on a strip of paper or in a cup there, because it's waking 30-30. It's much easier to pop a cotton salivette swab in your mouth and just get it done. We still want that dinner and bedtime sample, though, when you're evaluating a cortisol awakening response, because I want to know your entire circadian rhythm. I want to know why you're not sleeping. I want to know why you're anxious at night. I want to know why you're so tired in the afternoon. I still want to know all of those things. This is what the whole curve looks like. Now, you would think to yourself, well, that gray area is what we saw earlier, and it looks very, very similar. It is very similar, but this is zoomed in. So this, as you can see along the bottom, waking 30-60. So it's a very, very quick up and down within 60 minutes, and then it continues to decline for the rest of the day. This is what a healthy cortisol awakening response looks like. So it should look like a nice mountain. It should not look like, a blunted hill. It should not look like a flat plains. It should not go straight up like a rocket. This is what it should look like, ideally. It's also important to note when you're dealing with cortisol that your morning cortisol, even no matter what, should be higher than your afternoon and your bed sample. So no matter what, you should have higher cortisol in the morning, higher physiologically, so higher normally. But if you test yours, or you test your client or patient, and you see their waking is below the afternoon point, like that can incite a lot of comorbidities and can be concerning. So make sure that when you're evaluating, you want the morning point, the waking point, at least above the afternoon point and the night point. That's what you're going for. All right, so when we're doing cortisol awakening response versus 4-point cortisol testing, what's the difference? You might think, well, isn't a broad overview just as helpful as the cortisol awakening response? So let's look at this. So this is urinary free cortisol pattern. These are two different people, patient A on top, patient B on the bottom, and you can see their test results look very similar. So the blue shaded areas where they should be, they are the blue solid line that I have circled in red. So look at that B point that was collected between 6 a.m. and 8 a.m. for each patient. So you might look at that and think, wow, you're kind of below the mountain. You don't even make a mountain. I bet you're tired, and I bet you have blood sugar issues, and I bet you have inflammation, and I bet you wake up with pain, and it's possible your autoimmune symptoms are getting worse. But when we zoom in and look at the cortisol awakening response, patient A on the top continues to stay low and flat. So they are not resilient at all. Whereas patient B on the bottom, they actually, when we zoom in to see waking 30 and then 60 minutes, they actually make a little peak. They actually go up. So this tells me that patient B on the bottom is more resilient than patient A on the top. So this is how we use that to determine resiliency. Are you at a 0 or are you at a 2 out of 10 when it comes to your energy and feelings of burnout? So more HPA axis resiliency with that person B. They can still get a rise in cortisol. They still have some oomph. We just need to help them push it up a little more. Whereas patient A is going to require a lot. So patient A, as I have written, consider stronger HPA supplementation, which you're going to learn about later this afternoon. They're more at risk for the sequelae, fatigue, autoimmune, inflammation, metabolic syndrome, etc. Whereas patient B, they have a response. Their support is not going to need to be as powerful, and they'll probably recover more quickly than patient A. So when you see these things and they start to ask you, well, how long do you think it'll take to make me feel better? Patient B won't take as long. I mean, I can't give you, down to the, day, week, or month, but as you do these more and more, you'll start to recognize like, patient A is probably going to take 6 months or more, to really start to turn things around, assuming that they're, listening to all of your suggestions. Whereas patient B just needs a little more oomph to get them up into the blue range, and probably won't take 6 months, as long as they're following your protocols that maybe take them more like 2 to 4 months instead. So when it comes to your cortisol awakening response treatment, is you're gonna learn more about cortisol treatment nutrients and whatnot this afternoon. So any treatment recommendations, consider doing within 30 minutes of waking, because you're trying to affect that cortisol awakening response. So if you're listening to this and you're thinking, well, I am totally that person who needs 2 hours and 2 cups of coffee, and if you have supplements that you take in the morning, most of you probably don't take them on waking. Most of you, and I'm for sure guilty of this sometimes, you have morning supplements, but you put them in your pocket or you set them on the counter, and then you drink your coffee, you get ready, you get going, and then you're like, oh, my supplements, I forgot. And we know our clients and patients do the same thing, right? We know that we're like, okay, take this in the morning, and they may take it an hour after breakfast. They may take it 2 hours after breakfast. They may forget and take it at lunch, which is still helpful in the grand scheme, because as Tom said, a lot of these adrenal supports are actually brain supportive, which is really, really helpful. But if we're trying to really get with the cortisol awakening response, consider what you're taking, what you've been prescribed or you're starting. Consider doing it within 30 minutes of waking. Now, the big caveat here, I fully understand, is if you are on thyroid medication. We know that thyroid medication is a diva, and she needs to be the only thing in your stomach for some time before you can take anything else. So in that case, then you should wait. You let thyroid do her thing, and then maybe you'll take your nutrients or your multi or B complex or whatever you're taking, your adaptogens, maybe an hour after your thyroid medication. You just do the best you can. So let's look at a few examples of what might walk into your pharmacy, or might talk to you, or maybe you'll recognize this in yourself. We'll just look at a few examples to kind of show you how maybe same symptoms or similar symptoms could generate different results. So how do you look at this? So again, on the left is the free cortisol pattern. So this is your up-down pattern through the day. Again, in the blue is ideal, and the solid blue line is their actual result. On the right-hand side, we have their free cortisol all added together. You read it like a speedometer. So this in between the stars is the normal range, and then it's kind of like a gauge, right? So then in this example, the gauge is way up, it's 263. And on next to that is your metabolized or total cortisol production. So that's, can they make it, and how much of it is free? So in this example, the person makes normal amounts of cortisol, 4,469, but their free cortisol is really high at 263. And the patient reports difficulty staying asleep and wakes up early. So you can see that waking point is high. No wonder they can't stay asleep, and no wonder they wake up early. Their HPA axis kicks off probably sooner than they want. And the reason for that are potentially stress in their life, anticipatory stress for the day. They have poor sleeping habits in general. Maybe they snore. Maybe they have sleep apnea. Maybe, there's multiple, they co-sleep with their family, and the kids or toddlers that are keeping them awake all night long. Maybe there's an entrepreneur who is on their phone or their computer until late in the night, and they're getting a lot of that blue or white light stimulation. Maybe it's blood sugar, insulin issues. That's a big trigger for increasing cortisol. Maybe alcohol before bed, especially sugary alcohol, the body has to process. And especially as women become perimenopausal and menopausal, they'll tell you this. Like, I used to drink wine, and now when I drink wine, I get hot flashes and night sweats, and I can't sleep. Like, I know your enzymes have shifted in your liver, and it's affecting the way, of course, then your blood sugar, which is affecting your HPA axis, and then it's keeping you awake and making you feel terrible. Maybe gut health stuff. We know some parasites that can be active at night. Other causes for inflammation or infection, mold or Lyme or Epstein-Barr or what have you. And then consider calming supplements, calming supports. What can you do? This is where we address the cause, and then we band-aid using, calming nutrients, calming supplements, which will be discussed later when it comes to treatments. Now, this is a different person, different patient, but with the same exact results and similar complaints. This person says, I feel wired at night and I can't fall asleep easy. So it's the same absolute numbers, but a different cortisol pattern. This person actually starts to rise before they go to bed, as opposed to having a higher waking point. So this is why testing is really nice to go, oh, in the first case, their cortisol was rising earlier, let's address that. And in this one, the cortisol is rising in the evening as they're getting close to bed. So everyone else is winding down and they're winding up. So here's a different example. A 40-year-old female, she says, I'm tired in the morning and I can't sleep. And so when we look at her pattern, well, let's start on the right side. Her metabolized cortisol is normal at 4,786. So that again tells me she's producing normal amounts of cortisol. Production is not her problem. Timing is her problem. There's her morning point. Again, she's supposed to be in the blue shaded area. So she starts out kind of scraping the bottom of the barrel, and then she's low, and then she comes up at night. Now, we call this pattern, we tend to call this pattern either the mom pattern or the entrepreneur pattern. Because what happens is moms and dads and entrepreneurs will be with the family in the evening, and they'll put the kids to bed, and then they get their second wind, and they can now get on the computer, and they can now get a lot of other stuff done, right? Or they can now go through the mail and pick up the house and, you know, start some laundry, and it's finally they have some time to themselves. And so they're doing as opposed to winding down. And so the brain sees all the light and all the activity and was like, okay, cool, I will pump out more cortisol as opposed to melatonin right now and keep you going. And then they can't sleep. And so they wake up in the morning and they're really tired, and then they rely on caffeine, and they continue, and the process just starts all over again. So in this case, it involves a lot of retraining. So in this case, it's within 30 minutes of waking, I'm like, hey, light is really important. So full spectrum light exposure on waking. So either go outside or open your blinds, you know, open your curtains. Consider buying a full spectrum light box online. They're pretty inexpensive. Consider buying a full spectrum light alarm clock that wakes you up gradually with, like, fills your room with light. Light exercise or stretching in the morning on waking, or going outside and when it's sunny and stretching. Brain health support. Again, remember I said a lot of this communication starts in the brain. Tom talked about how a lot of adrenal support is really actually brain supportive because and how it communicates down to the adrenals. Mitochondrial support, you'll learn about nutrients later today, about mitochondrial support because that's where cortisol is made in the first place. And then the adaptogens and the other adrenal support and other adrenal nutrients that you're going to learn about, like B5 and vitamin 6, or B6, vitamin C is what I meant to say. Vitamin B5 and vitamin C, which are important for the adrenal glands. So you don't have to do all these things, but because that can sometimes be overwhelming to people, but, you know, maybe pick one, like, hey, in 30 minutes, when you get up in the morning, I just want you to open your blinds, open your curtains, or I want you to stand outside for a little bit, or stand at your window and appreciate the fact that the sun is out for 5 or 10 minutes and get that full spectrum light. Go walk your dog and, you know, outside, and don't put your sunglasses on for the, you know, 5 or 10 minutes, like enjoy the sun. And like to this morning when I woke up at, I'm on the West Coast, so 5 a.m. when I woke up, I have a full spectrum light box. So I turn my light box on. You're going to evaluate and address stress. Apparently it's so important I wrote it twice. Evaluate and address stress in her life. So evaluate and address the stress in her life. Evaluate the sleeping habits and blue light exposure at night, making sure she's either changing the color of her screen or using blue light blocking glasses, not putting on every single light in the house. Just be mindful of that. Addressing blood sugar and insulin, alcohol in the evening, gut health, inflammation and pain at night, because that could be a big trigger for cortisol. And consider calming supplements before bed. You know, calming nutrients, calming herbs, calming teas can all be really helpful. So here's a different example. This is a person who's very, very upregulated. High metabolized cortisol and free cortisol indicates an overall upregulated HPA axis. And we see this a lot right now. We see a lot of people who are super stressed out and they are sort of at a 10, right? They're at a 10 all the time. And they're just feel on fire. They tell you that they just feel kind of like a mess, or they everything's a struggle. The blood sugar is a struggle, their appetite is a struggle, their weight is a struggle, their hormones are a struggle, their female or male hormones are a struggle. They're losing hair, you know, their skin is not great, and cortisol amplifies all this. So in this example, obviously addressing the cause, and sometimes the cause is, you know, when you say, well, do you know what the cause is? And they look around like, yeah, it's 2020, what do you think the cause is? And in that case, what we're trying to do is just calm the system, give them the tools to help their body feel safe, whether that's, and self-care, whether meditation, breathing exercises, suggesting them to go to therapy, hobbies, picking up hobbies, trying to connect with their loved ones as much as they can. All of those things can be really calming to the system. And while you're just doing calming nutritive support, calming nutrients, calming herbs, calming teas again, making sure their sleep habits are good. Now, if maybe there's other causes though, like maybe you find out that they have been struggling with an infection. Maybe they've been, it's job related. It's not really 2020 related, but it's job related. Maybe they have been acutely sick recently. Maybe they sprained their ankle and their ankle is in a lot of pain all the time. Then okay, you know what the cause is. Cortisol is up for a good reason. Let's address the cause and then come back and look at the HPA axis again. Actually, I had a consult I did with a practitioner whose results look very, very similar to this. And the doctor said, I think your results are wrong because, or I think these results are wrong. What do you think? Would you look at them? And the gentleman who collected the test had actually written on his test form, I broke my elbow the night before I started testing, went to the ER, came home from the ER, and then got up in the morning and did my cortisol test. And I was like, well, this is what the result looks like with a broken elbow. So seems like a pretty standard result to me with a broken elbow. Maybe in 12 weeks, you should reevaluate that. And I would not do anything to suppress this with a broken elbow. Like, your cortisol should be high to manage the fact that you just broke your elbow and you're in a lot of pain. This is a normal response with a broken elbow. But for other people who are maybe reacting to 2020, to their job, to their families, to everything that's going on, we definitely want to support them as much as possible. That's much more long-term. So causes of high cortisol, like I said, stress, acute infection, inflammation, insulin glucose dysregulation, and then stimulatory medications, supplements, or habits. This is a good one to know. So the people who are addicted to Red Bull, the people who are taking maybe ADHD medication, maybe people who are taking phentermine for weight loss or what have you, and they do their cortisol testing, it can absolutely increase their cortisol. And of course, people are taking hydrocortisone for various reasons, whether they're using hydrocortisone cream because they got that, rash from being out in the garden, or maybe their practitioner has prescribed hydrocortisone or Cortef for them for low cortisol. And just be aware that obviously if you're taking cortisol, it will show up as cortisol. Prednisone is different, as you know. Prednisone is suppressive to the HPA axis. So it's different than giving somebody, like 5 milligrams of Cortef, or if they applied hydrocortisone cream. Please also remember that high cortisol can really have an effect on hormones like progesterone. So what happens over time is that they can inhibit that GnRH pulse. I said this at the beginning, and that results in less LH and less FSH stimulation. So as a little refresher, your GnRH pulses pulse differently for FSH and differently for LH. So it's like different phone numbers, right, for kids. So when the mom wants their daughter, they call a certain phone number. And when they want to call their son, they call a different phone number. It's the same thing. So FSH is dominant in the early follicular phase. The GnH pulses are slower and lower, and that stimulates FSH. Whereas LH, which is of course dominant right before ovulation and then through the luteal phase, those are faster and higher. So sometimes what we will see, or often what we see, is that cortisol will get that LH first because they're faster and higher, so it will dampen that. And when you dampen that, that makes it look more like an LH number, and so, or excuse me, an FSH number. So LH gets dampened, looks like FSH now, and then that stimulates. So now you still have estrogen, but not progesterone. And in extreme cases, cortisol suppresses both, and now they don't make FSH or LH, and oftentimes they have amenorrhea. Over time as well, there is a feedback loop. High cortisol can result in low cortisol. So if you are testing or testing yourself and you have very low cortisol, it's possible and probable that not that long ago it was high, but over time the feedback loop kicks in to protect you, and now you drop to low cortisol. So what happens is, at the top, stressors, inflammation, infection, what have you, build up. The hypothalamus then starts to decrease CRH, your ACTH decreases, your cortisol drops down. Now, when you drop down and everything's low, this is the pattern that you look like. So you want to be careful if you see this, evaluate for Addison, still do your due diligence, just like you would evaluate for Cushing's if somebody was really had a very high, their circadian rhythm was sort of high and flat as opposed to low and flat. But if it's not Addison's, this is where it falls into that functional endocrinology. So again, address the cause and support the HPA axis. What could it be that has caused their HPA axis to become low? Is it that they've been having a high stress and infection, inflammation, what have you over time? Or maybe they did a prednisone pack or got a joint injection and it's suppressed it kind of in a false manner. So long-term cortisol stress, long-term pain, infection, inflammation, suppressive medications I've mentioned. Opioids are another big one. Isotretinoin, for the skin, that can be another big one. The isotretinoin doesn't get a lot of press, but it is in the literature that it could decrease not only cortisol, but other things too, your male and female hormones and even thyroid. So be aware of that. Congenital adrenal hyperplasia, and specifically the non-classical where it looks kind of PCOS-ish, but it's maybe not PCOS. So checking, checking that 21 hydroxylase, checking that 17 hydroxyprogesterone, especially if they look PCOS-ish, but their cortisol is low. Traumatic brain injury to the hypothalamus, the hippocampus, or the pituitary. Again, these are the things that create all the signals that move downstream. So if you've had a TBI in any, either it's sports, whether it's military, whether it's a car accident, no matter what, you want to get that evaluated and addressed, because that's where everything starts, is with the brain. And then sleep deprivation. So speaking of, this is a 30-year-old male, severe sleep apnea, overweight, high blood pressure, waking fatigue, and depression. So you can see on the right-hand side, this male is producing a lot of cortisol, 10,300, they're above the range. So production is high, and then on the left-hand side, you can see that his pattern is all over the place. His waking pattern is low, and then he shoots up, and then he drops right back down, and then he shoots up again, and then drops down again. Now, in his case, we know that cortisol, that crazy cortisol, can absolutely have an effect on weight, on blood pressure. He's low cortisol in the morning, waking fatigue, depression. It can affect all of that. But that sleep apnea, the sleep apnea is actually the linchpin here. So the hippocampus controls the car in your brain. And the sleep apnea has a huge effect on how your hippocampus works. So by him not getting his sleep apnea addressed, it's going to affect the entire circadian rhythm. It's going to affect his androgen production. We know men make testosterone in their sleep, and so drops his testosterone production. It's going to affect his blood sugar and insulin function, not only for cortisol, but because he's not getting oxygenation to the brain. He's likely not making healthy levels of melatonin, which melatonin has a big impact on insulin receptors and glucose. It affects inflammation and more in a big way. So when your male or female patients are telling you that they do have sleep apnea, or they do snore, or they do have disordered breathing, or they mouth breathe, keep this in mind. So in summary, HPA axis dysfunction can lead to several comorbidities. Cortisol testing in urine, or a combination of urine and saliva for that cortisol awakening response, can help you further define the patient's bioindividuality. And again, know, once you understand what's happening with their cortisol, you can actively do something about it. Not only you, but them. They can see it on paper, and they can go, oh, okay, let's make some changes. You always want to address the cause, whatever that may be. Use supplements to support when needed. And honestly, this is what I say, proper sleep in darkness with full spectrum morning light probably helps greater than 50% of HPA axis issues. That's not in the literature, but having done this a lot of time and having seen thousands and thousands of tests, and knowing how problematic quality sleep is in the world right now, I think proper sleep and proper circadian rhythm could really help a lot. So that concludes our talk. Thank you so much for listening. I really appreciate the opportunity, and I'm excited for the rest of the speakers, because we will continue on learning more about things like treatment and what to do.
Oh my gosh, thank you so much, Carrie. That was wonderful. I just got an email of a baby picture yesterday from a patient, and We did car testing for her a number of months ago. And it's so funny what you said on the last slide. One of the first things I told them to do was to get light blocking shades so she could get a good night's sleep. And then we started her on a meditation and yoga plan. She'd been trying to get pregnant for 6 years.
Wow.
And we did no drug therapy whatsoever, other than obviously monitoring her progesterone during pregnancy. But to get pregnant with that GnRH, we just had to get her cortisol under containment, right?
Yeah, so, yeah. That's exciting. That's exciting.
Amazing stuff. Amazing stuff. So, thank you again, Carrie. It was wonderful. So we're going to go to a break.